for joining us. I think everybody here, we have heard her so many times in this forum. She's consultant, clinical geneticist, MS Obs Gynae. Okay, should I press allow? Yeah. And she's a DNB super specialty in clinical genetics, and she's a proud gold medalist certified, and she's also certified from the European College of Medical Genetics, New Delhi. So, Dr. Veronica, there's a lot of confusion among obstetricians. They're not very clear about what genetic test to order when, and especially the basic backgrounds, and also what to do when to order chromosomal microarray, when to order West, just the basics. We don't want to go too much into the depth because those will be looked after by you and people like us. So, I invite you to start your talk.
Thank you. Thank you so much, Deepika ma'am, for this wonderful platform that we all have and which has nurtured so many of the obstetricians in the past years. Whichever meeting I go to, everyone talks about you and this platform. So thank you for doing this. And
Do
I'm
they really? Okay.
yes,
I'm
yes,
glad.
they do, ma'am. They really do. So it was recently in the Greater Noida obstetrics meeting as well. So it's amazing. So thank you, ma'am, for this opportunity. And I'm sorry I this got delayed. So before we start about which testing, first a little bit about when you want to think of a genetic disorder in your patient. So do try and make a little bit of pedigree or a family, take a little bit of family history. You don't know by asking just one or two sentences what all information you can gather about any genetic disorder. You can just mention intellectual disability like mandabuddhi, deafness, blindness, etc. An advanced maternal age, recurrent pregnancy losses, fetal growth restriction, sonologically detected fetal anomalies, history of infertility, premature ovarian insufficiency, and primary amenorrhea. So, in obstetrics and gynecology, these are the main indications where we think of genetic testing. And of course, the previous child or any person in the family with suspected genetic disorder. So, we all know about this common thing that we have a cell. A cell has chromosomes inside it. It's like a library which has different sections, chromosomes, and then the chromosomes have genes on them which are like the page, and each gene is further made up of exons and introns. So genetics as a whole is the study of this genome, and chromosomes are thread-like structures inside the nucleus. We can study the chromosomes for chromosomal disorders, and on them we have genes which we can study differently. When a person has all 23 pairs of chromosomes in copy numbers of 2, this state is known as a euploid state. So we are all euploid individuals. When a person loses or gains a chromosome in them, this is known as aneuploidy. Aneuploidy can be an extra or a missing chromosomes. So an aneuploidy is the loss of euploidy. What is polyploidy? Polyploidy is a change in the chromosomes in the multiples of n. That is, instead of 23 pairs, we have 46 pairs, or we have 99 pairs, etc. So 69 pairs, etc. So the genetic changes can be chromosomal, as we just discussed, or they can be gene related. Now, chromosomes and genes are different. Anything related to genetics is not just genes. Chromosomes do have genes on them. Each gene on a chromosome is placed like a pearl of necklace in tandem, that is, one after the other. Now, each gene again then is made up of all these letters which are placed one after the other. What is a mutation? Mutation is what occurs when one part of the gene gets changed into other, that is mutated. In a healthy person, in the gene coding for hemoglobin B, that is the thalassemia disorder causing gene, normally at this position we have the nucleotide T, that is the letter T. But a person with beta thalassemia may have a letter C. So we need to test for this point mutation because there is a mutation at one point. This is known as a point mutation. So we need to test for this point mutation. So the checking of this point mutations helps us not only make a diagnosis but also to provide prenatal diagnosis in the next pregnancy. So these are the tests at a glance that I'll be discussing today. I put in a lot of effort to make this slide, and if you all like, I can also share a PDF of this slide, but it's great you can just have a screenshot and use it for counseling. For obstetric prenatal indications, these are the most important tests that I have listed. On the left, you have the chromosomal test, and on the right, you have the gene related test. We will be discussing the details of each test in the upcoming slides. So, first, we have the gene related test. That is so first we have the slides showing different components of tests. The fish karyotype and CMA are tests for chromosomal disorders, and single gene, and for gene related disorders we have single gene related tests, that is Sanger, and for all genes together we have exomes. So let's start with the first test that was discovered, and the test that is the most basic test in genetics, that is a karyotype. Karyotype is a test which looks at all chromosomes together under a microscope. When do you want to do a karyotype in obstetrics? If you're suspecting some disorder in which there is a big part of the chromosome missing or chromosome extra. For example, if you want to only check for Down syndrome and you don't want to check for any small deletions or duplications in these chromosomes that we are seeing. So this is the karyotype. So when there is an additional chromosome here, or everything is present in copy number of 2, but if you want to just see if there is an additional chromosome, you can do this karyotype. But if you wanted to see this number 2 is missing, then karyotype is not a good test because it can't pick up small missing or additional chromosomes. So karyotype is a good test when there is a screen positive in first trimester or second trimester, or there are fetal malformations which are very specific for chromosome number 21, 13, 18, etc. But overall, this test is not so useful when we are looking for all genetic disorders together. Then we come on to FISH test. FISH stands for fluorescent in situ hybridization. FISH test you do when you want a quick report. It will give you trisomy 13, 21, X and Y reports, but the advantage of this test, it's a rapid aneuploidy test. It is only an adjuvant test to a karyotype or microarray. The limitations of this test are it requires prior knowledge of specific chromosome abnormality to be investigated. It will not pick up all chromosomal abnormalities. You need to first decide which chromosome number FISH you want to do. So this is how a FISH probes look like here instead. So normally every chromosome will have 2 dots on the FISH test, right? But if there is a trisomy here, so we can see 3 dots, the report comes in 48 hours. So you can give your patients the report quickly. Then we come on to this test called MLPA. MLPA stands for multiplex ligand probe dependent amplification. This test is not a routinely done test in obstetrics, but there are some disorders, some common genetic disorders like DMD and SMA, which will be not caught on your microarray or on your exome sequencing. For this, you need to do MLPA. MLPA looks at deletions and duplications which are even smaller than the levels of genes. So for Fragile X, for DMD, for SMA, you want to do MLPA test. Now we come on to the most important test in obstetrics, that is the chromosomal microarray. Chromosomal microarray looks at deletions and duplications in the chromosomes and it looks at the smallest deletions and duplications. So it is a very good technique for detections of chromosomal abnormality. It has improved the diagnostic yield of testing more than 15 to 20%. Even in the absence of any structure, please read the line here, even in the absence of any structural malformation in the fetus, it can provide an additional 1 to 2% information. So, what are the indications and testing where you will do microarray? It is the test of choice in fetuses with fetal malformation, fetuses with fetal growth restriction, multiple soft markers, and product of conception in recurrent pregnancy losses. So it is not a good idea to perform this test in the couple with recurrent pregnancy losses, because microarray will be abnormal only in affected individuals where there is a chromosomal abnormality. In couples with RPL, we are really looking not for an abnormality but for some translocation of a chromosomal material. This balanced translocations is only picked up on your karyotype. So you can definitely and preferably do microarray in your screen positives, fetal malformation, fetal growth restriction, multiple soft markers, but in your couples, you want to do a karyotype. So let's just discuss one case when microarray should be done. This was the first pregnancy of a non-consanguineously married couple. The anomaly scan identified fetal growth restriction, congenital cardiac malformation, and agenesis of corpus callosum. So, one straightforward rule is that in presence of multiple malformations, the test of choice is chromosomal microarray. Hi, I think there was some disconnection.
Yes, ma'am. We couldn't hear you,
Yeah.
but audible now.
Audible.
Ma'am, you're again on mute. Sorry.
Okay, right. So this was the first pregnancy of a non-consanguineously married couple. Again, history of consanguinity is very important. Consanguinity means marrying within the relatives, and there is another history that we routinely take is of endogamy, that is married in the same community. So for every couple, you want to take this history, especially for couples with malformations. So in multiple malformation test of choices, microarray, I don't think. हाँ, but if there is only a specific malformation, how we decide the testing, we will just come to that. So here there was a family history on the paternal side of recurrent pregnancy losses. A fetal sample was tested for CNVs by the CMA. And CNV is copy number variation. Copy number variation, this term may sound very complicated, but it only means that if there is any chromosomal problem of a smaller size. Of a big deletion, that is a 5 million base pair deletion, was present on the sixth chromosome, and there was a 23 million base pair duplication on chromosome 4p. So there were two abnormalities that were defined on the microarray, and this now we had to predict if this was disease causing or not. So this was the abnormalities that was seen. As you can see, there was a part of the chromosome which was duplicated here, a huge part, that is the 23 million base pair part, and a small part of chromosome 6. As you can see, these lines are below, these dots are below the line, so this shows deletion. So there are two abnormalities that are seen in this report in the fetus. Whenever you see more than one abnormality in a fetus, it means that the parents may be carrier of a balanced translocation. So we did a karyotype for the parents, and they were actually carriers of balanced translocation between chromosome 4 and 6. So this made their risk of recurrence in the next pregnancy very high, and we offered them a prenatal diagnosis as well as PGT-SR, that is pre-implantation genetic testing for structural rearrangements. So this is how we can counsel on the basis of genetic report. Now, chromosomal disorders can be fairly straightforward. That is Down syndrome. You can do a karyotype, but generally karyotypes fail in products of conception and fetuses. So in such cases, you can do a DNA-based test like a PCR, or you can do a microarray. Again, this fetus antenatally suspected trisomy 18. For trisomy 18, fish will be the targeted test antenatally, which will pick it up and give a report in 2 days. And you can do a karyotype also antenatally to know the type of Edwards syndrome. That is, it's a translocation Edwards or a free trisomy Edwards. But most of the time, you will not have a genetic diagnosis just by looking at the fetus. And here you cannot do any targeted testing. You want to look at all chromosomes together. So this is a fetus with unilateral anophthalmos. Anophthalmos means absence of one eye, and cutaneous syndactyly as well as cleft, which we can see. So in presence of multiple malformations, let's be clear, our test of choice is chromosomal microarray. Again, I have heard from some obstetricians when I discuss, हम directly exome क्यों ना कर लें? Because exome will pick up different things and microarray will pick up different things. This is like saying that if there is some giddiness in a person, why don't we directly pick up do sugar testing and not do BP testing? That's how different microarray and exome are. They are looking at completely different things. So exome sequencing is not a replacement of microarray. So now this was a fetus which was terminated in view of nucleoedema. You can see this nucleoedema is huge. So antenatally, a fish was sent to quickly tell us about trisomy 13, 18, 21. Purpose of fish is only quick. Fishes are quick, so we just have a quick report, nothing else. Now, second test was microarray. It gives a detailed description of all chromosomes, which may cause nucleoedema. That was again normal. But in presence of nucleoedema, and especially in presence of a recurrence, we need to do further testing. Once we have ruled out chromosomal disorders, we still have not picked up mutation related or gene related disorders. And here we come back to gene related changes. You have done microarray, you've seen if like parts of chromosomes are not deleted, not duplicated, parts of chromosomes seem okay on microarray. But do we pick up these mutations? No. So now we want to pick up these mutations, and for these mutations, we want to do next generation sequencing. That is sequencing of all the nucleotides together. And it is important, and this is known as exome sequencing, and this is important to know that exome sequencing is highly phenotypic driven. That means that जो phenotype आप laboratory को बताओगे, whatever you tell the laboratory, that is what they're going to analyze the exome in. So we now do the exome sequencing in-house in our hospital at Gangaram, and there are two sets of people who do the analysis, the laboratory people and we ourselves, the clinicians, because the exome sequence is dependent on your clinical phenotyping. That is, you give a good ultrasound report. You also, if the fetus is terminated, give an autopsy report and maybe an MRI report. So there is something known as a human phenotype ontology, and when we are doing exome sequencing, we put these terms like agenesis of corpus callosum, partial agenesis, mild ventriculomegaly, severe ventriculomegaly, type of brachydactyly, type of shortening of the corpus callosum. So all these terms have different numbers assigned to them, and your report will be of a good, better diagnostic yield only when the phenotype is good. So fetal medicine scans, fetal medicine specialists play the most important part here. Do make sure one of your scans in case of anomalous fetuses is being done by specialists like Deepika madam to be able to give a good diagnosis even in the genetic tests we perform. So then we have postnatal examination of the fetus, which also adds some utility after a good ultrasound scan is done. Some things may be missed by ultrasound at a lower gestational age, which we may pick up. So we did pick up a tracheoesophageal fistula for a pregnancy which was terminated at 18 weeks, and scan did not show it. So definitely everything is additive, and in integration we all work the best. So exome sequencing refers to the genetic testing of the protein coding area of the genome. The genome is huge. We almost get a 15 to 16 GB data on the genome, and we don't need that much for the analysis on a clinical purposes. Exome is only 1% of the genome, but it has 90% of the significant information, and that's why we perform an exome sequencing. There are three types of next generation sequencing: exome, what we also call it whole exome. Then we have whole genome, the one which gives us too much data but we get lost in the data. So please do not order whole genome for your diagnostic purposes. Clinical exome is a good test. It will give you data only for genes related to your phenotypes or for diseases which have been defined today. So, a good test to do, which will help you in the future also, is a whole exome for your fetuses after you have ruled out the microarray abnormalities. Now, what do we do when we first have a malformation in our hands? A patient comes to you, you see at the malformation report, then you try to understand if it is a malformation or a marker. If you have a ventriculomegaly of 10 it is a marker for Down syndrome, but if it is of 20 at 20 weeks, it is a malformation. All malformations need invasive testing, all markers do not need invasive testing. Malformations will be pathogenic, will cause some effect on the fetus. Markers may be transient. Differentiate first time occurrence from recurrence. You will yourself feel more confident, and the patient will be more confident in testing in a recurring case. And definitely ask for detailed family history. So I've left out the first point here because I wanted to emphasize on it. It is the most important. Presence of a multiple malformations from isolated malformation is one most important thing for prognostication and syndrome identification. An isolated systemic malformation is what we're most scared of because we do all genetic tests here antenatally, and we need to tell the patient how the baby will be prognostically. If we have multiple malformation, it is most likely to be a poor prognosis, and we can more confidently offer discontinuation. Overall, counseling in all cases has to be non-directive, but an isolated from a multiple malformation differentiation remains most crucial. So for this, again, we need fetal medicine specialists to give us confidence, and because all our reports depend on that. So I had a patient yesterday with binder facies and written some small calcification on the ulna. Now I could have just taken it on the word of mouth and did an invasive testing for that ulnar calcification, thinking it was chondrodysplasia. But a better way is to get the scan done again from a fetal medicine specialist, which I got it repeated, and it was an isolated binder. Now, an isolated mild binder facies is very common. The patient's profile may be the same as well, and it does not always need invasive testing. So we need to know when to offer this testing, and of course we're all there to help. As a rule of thumb, all fetuses with multiple malformations should undergo invasive testing and microarray, except when there are certain disorders which we know will be picked up on exome and not on array. Now, when do you want to order an exome? See, you can order an exome anytime, but the interpretation is extremely challenging, and it only leads to testing again and again. So we need to quit thinking that ordering an exome will help the patient feel more confident. It will help you feel less confident once you have a variant of uncertain significance. So we order an exome when we are very sure that we are thinking of something genetic and when there are hard handles. When there is an early onset fetal growth restriction, you can only do a microarray. But when there is a recurrent early onset fetal growth restriction, you order an exome also. When there is an increased NT up to 5 mm, you can only do chromosomes. But of course, there are certain few cases where you can do exome and it can give you an answer as well. So increased NT and the chromosomes are normal, exome sequencing or a panel sequencing for certain disorders related to increased NT is an option. Very important to do exome when you have involvement of an isolated system like bones, that is skeletal dysplasia, like kidney, that is polycystic kidney disease, or like your brain. If you have an isolated agenesis of corpus callosum, exome is a good test. So when you have multiple malformation, directly go for array, but when you have an isolated malformation, there is some consulting required about which test you want to perform first. So, as I discussed, that interpretation of a variant of uncertain significance is at the heart of exome sequencing. In pregnancy, if you want to do an exome sequencing, the best idea is to do a trio whole exome sequencing, that is to test the fetus and the parents together. Only when you do a trio exome sequencing, you will be able to take care of the variants of uncertain significance. Because against the ticking clock of the against the ticking clock that we have in pregnancy, to do one exome after another, we will easily cross our timelines of 24 weeks. So it's best to do a trio exome sequencing. And then comes the variant of uncertain significance, where we need to do a genotype phenotype correlation and study the characteristics of the variants. That's for us to do. But even after we do all this, we can get stuck in a lot of cases. So the first and the most important rule is to order a test only when indicated. This will lead to less pregnancy termination on variants in which we are not sure will be disease causing. For example, in a fetus with increased NT, if you have an autism susceptibility variant, you can never say if the susceptibility will cause disease or not, and a lot of couples may end up terminating the pregnancy because of that. So we work a lot to really understand that when the variant can be changed from a variant of uncertain significance to pathogenic. This is the American College of Medical Genetics classification. We need to see which domain this variant lies in. For example, here it lies in domain 5. We know that most disease causing variants lie in this domain only, so it is likely to be disease causing. The classification of variants can change from year to year, from time to time, and is time dependent. So whenever you have an older report, ask your geneticist to review it again and tell you if it still is valid. So this is example of a couple with two fetuses with arthrogryposis, ventriculomegaly, Dandy-Walker malformations, and enlarged kidneys. Microarray was the first test to do in presence of multiple malformations, which when normal, we did an exome and it showed a very rare disorder, which is known as COG-related congenital disorder of glycosylation. This is a very rare disorder and you will only find it when we do a whole exome sequencing. So when there is a recurrence and your microarray is normal, you can go ahead and do exome sequencing. In 30% to 40% of the cases in recurrence as well, we will not get a variant in exome sequencing. And that's when we can consult with a geneticist and do a whole genome sequencing. Whole genome sequencing, in addition to exomes, also looks at intronic areas or intronic variants, that is the non-protein coding area of the genes. This was a family that we dealt with. They had 5 abortions due to polycystic no, due to renal agenesis, 5 abortions due to renal agenesis. There was consanguinity. So 5 times the fetus has renal agenesis. We've done microarray, we've done exome, we haven't found anything. Then again, we had a family which also came from Dubai for the same recurrent renal agenesis, and we did genome for both and found common areas where there was something happening, some mistakes in the genome. And in this gene, we found a variant, that the GFRA gene. The GFRA protein is involved in the ureteric bud formation, and when there was mutation in this GFRA gene, this led to absent ureteric bud formation and renal agenesis. So finally, the genome gave us an answer. In cases where there is recurrence, nothing is giving you an answer, we can consider genome sequencing. So now there are a lot of challenges in performing tests in the fetal scenario. That is, there is limited description of fetal phenotypes or of malformation syndromes. There are involving phenotypic expressions at different ages of fetal malnutrition maturation. Each time there may be a new expression, so we keep on, as I said, it is phenotypic driven, so that new phenotype may lead to a new gene that we may find. Additionally, the ever ticking clock necessitates quick decision making due to legal limits of pregnancy discontinuation. Even worse, now that those limits have been taken out, you need to offer genetic testing to all of your fetuses with malformations. So, the testing has become more prevalent, but has the testing become more accurate and more informative remains the question. So I hope this talk was useful, and thank you so much for your patient listening.
Thank you, Dr. Veronica. That was very crisp and in simple language. So I guess it didn't go over our heads, and we have been able to understand. Everybody could understand. Dr. Suchira, would you like to say something? And then I'll look at the question
Thank you,
answer.
Dr. Veronica. It was very informative session. And yes, a few points that you highlighted, that microarray should be done if there are multiple system involvements rather than a single system. And if there is a single system involvement, then VES is more useful. Also in
That case, we
binders.
need to individualize.
Yes.
Yeah.
I mean, yes, depending upon what we have got on an ultrasound or on a autopsy report. And binders also very well highlighted. Because we get so many binders these days.
So
If
every
they're
binder, we don't need to do an invasive
invasive.
testing. Look at the face of the mother, look at the angle, the
Yes.
severity, and maybe if it is, and do an ENA profile, because a lot of times associated with autoimmune disorders. So if
Yes.
all that is fine, we can avoid the testing.
Yeah, I think in binders, the biggest problem is the cosmetic.
Yes.
Cosmetic.
Yes.
Yeah, the cosmetic thing.
Yes.
So really there is a lot of confusion among obstetricians. They, in fact, order themselves to VES, when it is not very required. Of course, it can be done. So I wanted to ask you, Dr. Veronica, people abroad, they're now doing VES as a preconception investigation. So I think it has its usefulness, because very often we do find patients coming with a very rare genetic condition.
Ma'am, preconceptional meaning when?
Before they conceive.
You mean
Part of
carrier
carrier
screening?
screening?
Yeah, like a carrier
Okay,
screening.
okay. Yes, ma'am. Okay. So, yes, so carrier screening is a very good test to do, ma'am, as you said, because it will give us, we only test for thalassemia. Thalassemia is one recessive disorder. Now, we should also test for SMA, and in addition, they can look for all recessive and inherited X-linked disorders. It's a great idea to do it. Yes, ma'am.
Yeah. Okay, I can see two questions here. One is by Anonymous. If there is a family history of autism, then which test during pregnancy can be helpful in giving the idea of autism?
Right. So, in family history of any disorder, please check the person with the disorder first. That is the proband with the disorder. We evaluate, we do the testing like Fragile X, like microarray on the child. And then if there is something genetic, then you test the pregnancy. For no condition can you test the pregnancy directly in absence of any malformation. For a family history, always check the child first.
Yeah. You can see there's another question in the box also.
Yes, ma'am. I want to ask if there is an anomaly in baby which is not compatible with life. Is it necessary to do a genetic testing as it saves cost? Thank you, Dr. Gunjan. As always, great question. No, it is not necessary. Just make sure that post delivery you have told your obstetrician, or if you are your obstetrician, that the samples, how the samples should be saved, right? Because that is very important. We always do advocate, ma'am will agree, that amniocentesis will give you a better tissue to test. But I completely understand there are people who will want to not do further testing in the antenatal period. So take the part of the placenta where the umbilical cord inserts, that part, or take the sample of a spleen of or liver from the baby itself and store it in normal saline, and try to send it to the laboratory as soon as possible for DNA extraction. And if you have some lag period, store it in the refrigerator at 4 degrees Celsius. Otherwise, if all these facilities are not available, then antenatal should be preferred. Ma'am, anything from you?
Yeah, I've had real problems. Suchita will also bear with me that the fetus itself is not properly collected. It somehow pops out in the bathroom. So that can happen. And secondly, there was one case where the obstetrician said that we sent the fetus, but the lab said we didn't get the fetus. Then Gunjan, you yourself had cases where it was a lot of maternal contamination from the products of conception. So I really don't know. I feel antenatally it is so much easier. You get a clean sample and you're able to do it. And it doesn't really matter if you're doing it in a dead fetus because you're covering with antibiotics. And as per what people think that, there will be DIC. DIC doesn't happen immediately. DIC takes 3-4 weeks to occur. So the mother is really not going to have any severe pouring, bleeding or anything. So any of the faculty who are here, would you like to give your comments? We have to close in 2-3 minutes because the Strand has another meeting coming up.
Okay, ma'am, there are many questions, so I'll just quickly take them. So for Fragile X, which test? Triplet repeat PCR, great. Yes, triplet repeat PCR. A baby with hypoplastic right heart syndrome with no family history, you do the exome sequencing as well as array. Array is the first test to do for hypoplastic right heart. Then no other abnormality, and you can tell them that once you have done the array, still there is a 3 to 5% chance on some abnormality on the exome. So if they would like to, then you can offer that test. If the child with autism has normal CMA, then what test? So once you have done Fragile X and even CMA, that covers most of the autism. Again, there are some 3 to 15% cases due to exome sequencing. If there is no recurrence, it is okay to do till microarray. But if they are very anxious, they can also do exome on the child. But if you're ordering an exome sequencing, please have a geneticist to look at the child, because we look at lots of things like neurocutaneous markers, etc. So microarray is not very phenotypic dependent, but for exome, a detailed examination of the person should be done. I think we're done.
Dr. Veronica,
Yes, ma'am.
nowadays different labs are offering different, somebody is talking about Exome Plus, somebody is talking about something else. Yeah?
Exome first, some people
Exome
say.
first, I
Yes.
don't know what it is.
And
Exome-
every lab has their own names, as if you're giving a namkaran. So
So, ma'am, that they want to sell more. So, ma'am, the best would be if they are doing the exome with mitochondrial genomes, and they have ma'am, maybe this we can discuss in detail another day as well, or maybe in the
Yeah.
next lecture. That what are these tests? So we have some areas which are better integrated on the clinical exome for some tests, and for some tests they are clinically better indicated on whole exome. But whatever laboratories would be saying that doing exomes with with CNVs and mitochondrial genome together, we are fine. That's what we need. CNV,
Okay.
mitochondrial, and but I personally do not rely on CNV pickup on just exome. It is better to do array together.
Yeah.
I think there was a question. Did you answer this one? Testing a female fetus for DMD?
Yes, you can know if the fetus is PM. The PCT and PNDT form clearly mentions for X-linked disorders, we can know the sex of the baby, and you don't need to do the testing. But at our center,
Yeah,
we do not
but
use
yes,
such
I've come
tests.
across a lot of this X-linked disorders, especially hemophilia, some things like that, where they
Right.
still want to know whether the female is the carrier.
Huh.
In fact, the president of the Hemophilia Society once, his the fetus was this thing, female
Yeah.
carrier. Then he said, I don't want this because she will have to go through all these problems. So in our
Right.
country, like what you need to do is,
Yeah.
Dr. Atia, you need to counsel. But
And
according to the PCPNDT, for sex X-linked disorders, you can look at the sex.
yes, but you cannot tell the carrier state.
Yes,
We will
but
just say affected or
we
unaffected. Yeah.
yes, yes. But yeah, the report, it's always written in the report. So a lot of people, I think it makes sense also that you don't want to give birth to a carrier who, when she grows up, will again have to have prenatal
But
diagnosis to see.
ma'am, see, actually,
First option.
carriers cannot be. We do not encourage that at all. The termination of
No, I
carriers.
know we don't encourage
So,
termination, but in our, you have to see the social status of our country.
yeah. So basically, ma'am,
Mhm.
we don't report a carrier or not carrier. We will just write affected or unaffected. I'm not sure of labs, but I think most labs would kind of report it.
They
So,
would report, they always report that
but
they
let's just
carry it.
tell our patient baby is going to be normal and not having a disease. So
Yeah.
that would be good for
Yeah,
them.
yeah, but experience there all these years. So I really thank you all for attending this wonderful session. And I think Stan has something coming up at 6 o'clock. I can see them. So it'll automatically close up. So Dr. Bakshi is there? Is Dr. Bakshi there? Madam, are you there?
Check.
I don't see them now.
Acha, she's probably left.
And she had
But
is leaving.
yeah,
Okay.
okay. She said, I'm attending. So again, thank you all very much.
Thank you.
Right, ma'am. Thank you.
Bye-bye.
Thank you all. Bye. Good evening.
Thanks for